All right, guys, maybe we'll just go ahead and get started. That's okay. So my name's Zach. Today I'm going to be talking to you about myelopathies. The reason I chose this topic is because over the last several months, I've encountered a few cases where, despite all that Royal College exam studying, I thought I had some knowledge gaps in terms of both awareness of clinical entities and in terms of assessment and doing like a proper exam. So this round's really served as a learning opportunity for myself. And I hope there's a few key points that you can take forward with you and apply in your next shift. So to get things going, we're going to start with a case. You're working observation at the general, and you pick up the next chart, and it's an 80-year-old male who up until a month ago had been functioning very well. He had a history of type 2 diabetes, hypertension, and dyslipidemia. And up until a month ago, he was actually working full time. So you read the triage note, and it's kind of hard to make sense of. There's this 1 month history of bilateral leg weakness. He's got bilateral hand numbness, new issues with falls and imbalance. He's had some new ulcers on his skin. He was seen at a peripheral hospital 3 times. He's never been imaged, had COVID, he's type 2 diabetes. He had some inflammatory markers done that were elevated. And he was given prednisone. His sugars got high, and he stopped it. And then I went to assess the patient. I essentially got a similar history. He had a few-month history of worsening leg and hand weakness with new problems with falls and balance troubles, in addition to bilateral hand numbness. I went to clinical viewer. I note that he had 4 ED visits at an outside peripheral hospital, all for the same collection of symptoms. On the first visit, he was given a diagnosis of joint pain. A few weeks later, he came back and he was given a diagnosis of knee osteoarthritis. He came back again, like another week later, and there's this diagnosis of weakness. He had some inflammatory markers that were elevated. They said, maybe this is polymyositis. They started him on steroids. And then on the 4th visit to that hospital, the same diagnosis was preserved, and there was attempts made to transfer him to TOH for a CT scan of the head, but this was declined due to life or limb. The patient was offered admission in this peripheral hospital, but he declined and went home. So the 5th visit was, the big, we're driving to TOH visit. And when I saw the patient, he couldn't walk. So I wasn't really sure what was going on, but I had suspicion that this could be neurologic in nature. And, I kind of had to get a jail-free card because he couldn't walk, so I knew he needed to be admitted to hospital. The neurology was consulted, and they returned back to the ED staff working long after my shift was over, and they actually recommended an MRI of the C-spine. The MRI of the C-spine was performed, and it revealed central disc extrusion with inferior migration at C5, C6, causing severe cord compression, P2 signal abnormality. He also had moderate narrowing at C3 and C4, and C4, C5. With these findings, the patient was transferred from the general and admitted to neurosurgery for decompressive surgery. A couple months later, the patient still had some residual deficits, but improved significantly compared to pre-surgery. So the point of all of this is, what did our neurology consultants look for in an exam that allowed them to localize the lesion so precisely and make such a targeted diagnosis? What did they look for that myself and 4 other previous physicians did not look for? So keep this in the back of your mind, and we'll come back to it later as we move forward through the talk. So we're going to divide this talk into 4 segments. We're going to define what a myelopathy is. Second, we're going to talk about the physical exam and provide a framework about how to think about this. Then we're going to review degenerative cervical myelopathy, its diagnosis, treatment, and management. And last, we'll see if we can extend some of the learning points from this case and on tips from a physical examination and extend them to other concerning diagnoses that we sometimes see in the emergency department. But what is a myelopathy? It's a broad term that describes pathologic conditions that cause spinal cord, meningeal, or parameningeal space damage or dysfunction. These conditions can be traumatic injuries, vascular, infection, inflammatory, or autoimmune conditions. They can have devastating consequences such as quadriplegia, paraplegia, or severe sensory deficits. Early recognition is key, as many of these conditions may be reversible if recognized and treated early. One simple way to divide myelopathies is into the classification of compressive or non-compressive etiologies. Compressive etiologies refer to degenerative changes, trauma, tumor, vascular malformation, infections with abscess formation, syringomyelia, which is a fluid-filled cyst within the spinal cord. Of note, compressive disease is by far the most common etiology in older patients. And so once a patient with myelopathic features has had compression ruled out with an MRI, and there's ongoing demonstrated evidence of spinal cord inflammation, a careful history and physical can be done to tease out some non-compressive etiologies. The differential for non-compressive is exceedingly broad. Myelitis can be from viral, bacterial, or fungal etiologies, toxin, radiation-induced, metabolic, or perineoplastic. The workup and management of each of these is beyond the scope of what we can cover in these rounds. However, the heart of this discussion really comes down to when do you suspect this, what will you find on exam, and when will it reach that threshold where you say, I think this patient needs an MRI, I think they have a myelopathy. And so that naturally leads to our next section on the physical examination. So in order to suspect a myelopathy, you need to do a focused physical exam. The features consistent with a myelopathy can be very subtle, and if you're not specifically taking the time to examine for them, you're going to miss them, no question. The good thing is that they don't really take that long to perform. Now, we could spend an hour on this alone, so I just want to highlight a few key points that have helped reframe my thinking and solidified my own understanding. So when I was looking for resources, I found the primary texts of Rosens and Tintinelli not to be really that helpful, but I also found many of the neurology resources to be too complicated. I did find a series of YouTube videos from Matthew Jensen to be quite helpful, so if you have some extra time, I encourage you to check them out. In terms of basic anatomy, the spinal cord is a long, thin, tubular structure made up of nervous tissue that extends from the medulla oblongata in the brainstem down to the lumbar region, the vertebral column. The tapered end of the spinal cord is known as the conus, and it terminates around L2. After the spinal cord tapers out, the spinal nerves continue to branch out diagonally, forming the cauda equina. Another way to think about this is to take a slice and think about the various columns. We have the posterior column that controls ipsilateral proprioception and vibration, the cortical spinal tract that does ipsilateral motor, and the spinal thalamic tract that does contralateral pain and temperature and crude touch. This framework can be useful, and it's often utilized to help understand what would happen if a portion of the spinal cord was damaged, such as an anterior cord syndrome or a hemicord syndrome. I do, however, find this a bit hard to remember at times. I think on a day-to-day basis, there's some simpler approaches, and that's what I want to take you through in the next few slides. So, when thinking about the spinal cord, I like to divide it up in the collection of symptoms that you can have. The first is autonomic symptoms. Axons travel down the spinal cord that feed into autonomic neurons that emerge from the lower levels of the spinal cord. These nerves tend to have significant control over bowel, bladder, and genital function. This is really important because we spend so much time thinking about urinary retention in the setting of cauda equina, but I think we can really pigeonhole our differentials when we think like this. Urinary retention should really be a trigger to quickly screen for compression or dysfunction along the entirety of the spinal cord. The next basket to think about is somatosensory symptoms. Axons travel down the spinal cord and relay somatosensory information. They travel along the tracts that we have previously highlighted. Pain and temperature through the spinal thalamic tract, proprioception and vibration through the dorsal column. This is important as it brings forward the concept of a sensory level. The collection of somatosensory symptoms might help us localize to a particular level of the spinal cord, and in some cases, a particular column of transmission. Finally, it's good to think about upper and lower motor neurons. To recall, we have the lower motor neurons in green that extend out from the spinal cord and innervate skeletal muscle cells. The lower motor neuron findings receive input from the upper motor neuron axons, which extend the length of the spinal cord up into the brain. Damage to these upper motor neurons has a unique set of clinical characteristics, and if not routinely examined for, will be missed. So to the residents in the room, think to yourself, How often does someone push you on shift and ask you, hey, are there any upper motor neuron findings on examination? The collection of upper motor neuron findings are outlined above. We have absence of muscle wasting, increased tone, so it's important to take a patient's limb through range of motion, clonus, decreased power, hyperreflexia, an upgoing plantar response known as the Babinski sign, as well as the Hoffman sign. Lower motor neuron findings can be recalled as they are more or less the opposite, except for power testing. I think the majority of these findings should be quite familiar to most people, except the Hoffman sign. So what is Hoffman sign? The Hoffman sign was proposed by Johann Hoffmann, a German neurologist, in 1911. To test for the Hoffman sign, support the patient's hand so that it is completely relaxed with the fingers partially flexed. Then grasp the patient's middle finger proximal to the DIP and then flick the patient's nail of the middle finger. The test is positive if you're able to observe quick adduction of the thumb and flexion of the index finger. This is an upper motor neuron finding and can be indicative of an issue arising from the cortical spinal tract, most commonly in the C-spine. In some cases, it's considered to be the upper limb equivalent of the Babinski sign. 3% of the population will have this finding at baseline. So with this in mind, I really want to emphasize that it's the collection of all these symptoms and not necessarily one finding in isolation that should raise your suspicion for myelopathy. Think about autonomic symptoms, look for somatosensory symptoms, and examine specifically for upper motor neuron findings. Keeping this in mind, compression at T12 can present very differently than compression at L3, where the spinal cord is already terminated. We do a great job at documenting no features of cauda, but I think you can move things up just a few steps further. The patient can have no features of cauda, but still have a very worrisome disease pathology. So the big take home from this, is if you're not specifically looking for upper motor neuron findings on exam, you're never going to find them. All right, so let's talk about degenerative cervical myelopathy. So degenerative cervical myelopathy, sometimes referred to as cervical spondylitic myelopathy, involves spinal cord dysfunction from compression in the neck. Patients' symptoms are nonspecific, and they can report neurologic symptoms such as pain and numbness in limbs, poor coordination, and balance and bladder problems. Owing to its mobility, the vertebral column of the neck is particularly prone to degenerative changes such as disc herniation, ligament hypertrophy, or ossification and osteophyte formation. These changes are often collectively umbrellaed under the descriptive term of spondylosis, and it is these collection of changes that cause degenerative cervical myelopathy. In terms of epidemiology, overall a lot remains unknown regarding the true epidemiology, but we'll take you through a few key facts. Reviewing the literature, we note that the prevalence of surgically treated disease is about 1.6 persons per 100,000. Studies in healthy volunteers have shown that incidental cervical cord compression is commonly detected on MRI and becomes more common with age. In a series of randomly selected volunteers aged 40 to 80, incidental cervical cord compression was detected on MRI in 59% of individuals. And if you looked at just the 8th decade, this increased to 2/3, and only 2 of these individuals had reported symptoms. A proportion of these asymptomatic cord compressions will go on to develop degenerative cervical myelopathy. The exact figure is unknown. The only prospective study to consider this had 200 patients, and it found that 8% of individuals with asymptomatic cord compression will develop degenerative cervical myelopathy after 1 year, and 22% in total over the study period, which had a median follow-up of about 44 months. Interestingly, there is one small study that had 66 patients with hip fracture and found 18% who were previously undiagnosed to have clinical findings suggestive of degenerative cervical myelopathy. Taking this collectively, essentially the true prevalence remains unknown, but that's likely higher than reported, and many patients remain undiagnosed. So how is it diagnosed? It's really that suspicion with a targeted physical exam. Historically, the most consistent feature is evolution of symptoms. Progressive symptoms have been getting worse over the course of months. In the elderly, this can be challenging as their symptoms can often be attributed to age-related decline. Historical features include neck pain, unilateral, bilateral limb or body pain, upper limb weakness, numbness, loss of dexterity, lower limb stiffness, paresthesias, autonomic symptoms, falls, and imbalance. When we think about our physical exam, think about a lesion in the cervical finding and what we might find on exam. It's also challenging as symptoms may precede objective exam findings. Autonomic symptoms can be present. Somatosensory symptoms can be there. Upper motor neuron findings in both upper and lower extremities, and gait disturbances can be present. No one finding is sensitive or specific enough to rule in the diagnosis, but it really relies on capturing that collection of symptoms. I've talked a fair amount about the Hoffman sign. One systematic review published in 2018 by Fogarty examined the usefulness of the Hoffman spine, specifically in degenerative cervical myelopathy. 45 articles underwent full review. Only 3 were of sufficient quality and 2 with a sufficient number of patients. Analysis indicated that the Hoffman sign had a positive likelihood ratio of 2.2 and a negative likelihood ratio of 0.63. So a positive Hoffman alone will only lead to a small change in post-test probability of degenerative cervical myelopathy. So when that suspicion and physical are combined, the next step is an MRI of the cervical spine. Severe symptoms require urgent MRI, such as an inability to mobilize. Non-severe symptoms can have imaging on a non-urgent basis. A diagnosis is made when the patient has had appropriate collection of historical features, physical exam findings, and imaging demonstrating central stenosis with cord compression on MRI. When I reached out to our local expert, Dr. Stratton from our spine service, this was a key point she wished to emphasize. It's important to stress in the presentation that cervical myelopathy and cervical stenosis are not the same thing. Cervical myelopathy is that clinical syndrome diagnosis, and the radiographic diagnosis is cervical stenosis with cord compression. So back to our initial case. Our patient had progressive bilateral arm and leg weakness that had progressed over the course of a month. He had no neck pain noted at any point. Additionally, there had been loss of dexterity in using the hands. No bladder symptoms were reported. And on physical exam, he had bilateral Babinski sign and a bilateral Hoffman's. He had mostly normal strength, and he also had that inability to walk safely. So in this case, it's really that collection of the history, leading to suspicion, and a subsequent focused neurologic examination. So why is this missed? As previously stated, non-specific and subtle early features that overlap with other neurologic conditions can delay diagnosis. A retrospective study of medical records of 42 patients in Israel who underwent surgery for degenerative cervical myelopathy noted an average delay of 2.2 years from initiation of symptoms to achieving a diagnosis. On average, patients got 5.2 consults before a diagnosis was made. 43% of these patients had symptoms of numbness and pain in hands, and in many cases were initially diagnosed and treated for carpal tunnel syndrome. And the conclusion was that incomplete neurologic assessment by professionals with a poor awareness of the disease contributes to delay. Thinking about how we examine patients, one study sought to compare the difference in assessment between frontline providers and specialists. This was a 2018 study by Hilton, published in PLOS One, and this was at a tertiary neuroscientist center in the United Kingdom. And they reviewed all the MRI C-spines performed within a year and whittled it down to 43 patients who were diagnosed with degenerative cervical myelopathy. Once they had this information, they did a chart review and specifically looked at the physical exam documented by primary practitioners, specialist assessment. They don't really specify what a specialist was in this case, and then a surgical specialist. Now, this work is limited. Hold on here. Sorry about that. Now, this work is limited by a low number of cases, but I still think there's some key takeaways. Baby blue in this case means undocumented. We see a clear difference between initial primary care and the subsequent surgical assessment. Upper motor neuron findings of hyperreflexia, a Hoffman sign, and the extensor plantar reflex are routinely not documented. Differences were also noted in the documentation of limb pain, objective limb weakness, and lower limb spasticity. This highlights significant differences between how these patients are examined and highlights that incomplete assessments may be contributory to delay in early diagnosis and subsequent referral to spine surgery. All right, so let's say you have a patient that has the right collection of symptoms and an MRI of the cervical spine consistent with degenerative cervical myelopathy. I was able to discuss treatment recommendations with Dr. Stratton. He recommended all these patients be referred to and assessed by a spine surgeon for appropriate treatment recommendations. Patients with severe or rapidly progressive symptoms should be discussed with spine surgery on call or receive a spine consult in the ED. Patients with mild or slowly progressive symptoms can be assessed as an outpatient. Surgery is recommended in those with moderate or severe disease, and treatment of symptoms and regular follow-up might be offered with patients with mild stable disease or those with nonspecific symptoms and the absence of no upper motor neuron findings on examination. Decompressive surgery is thought to halt disease progression, but it doesn't guarantee any return of any lost neurologic function. So the true incidence of this disease remains much higher, likely higher than reported in the literature. Patients frequently experience delays in diagnosis, and in many cases can take years to receive a diagnosis. Delays are multifactorial, but inadequate assessment by frontline providers is likely contributory. Remember this diagnosis and keep it as part of your differential for the elderly patient with progressive weakness, gait disturbance, and falls. So remember it and examine for it. In your elderly patients with nonspecific symptoms, falls or weakness, screen for autonomic symptoms, incorporate somatosensory findings into your exam, and look for upper motor neuron findings in exam and document their presence or absence. Doing this could decrease that diagnostic window from 2.2 years down to hopefully much sooner and save a patient a couple of unnecessary consults. Surgical intervention can help disease progression and preserve function in those with more severe symptoms. All right, so now that we've talked about our exam of the spinal cord and highlighted some deficiencies in examination, I wanted to see if we could extend what we learned and use it to approach some other key diagnoses that often give us fear in the emergency department. And additionally, these diagnoses all have time-sensitive treatments that can be implemented and may modify disease outcome and recovery. So the first is the feared spinal epidural abscess. So let's start again with a case. This is a case I borrowed from the literature because I didn't have a recent one of my own. But you've got a 57-year-old guy with a history of hypertension that presents to the emergency department with worsening cervical pain. There's no history of trauma. He's diagnosed with an MSK soft tissue injury after an unremarkable exam, and then he proceeds to present to the emergency department several times over the course of a month. Finally, 30 days after the initial visit, the patient presented with worsening pain and reduced muscle strength. The weakness prompted an MRI, which revealed a cervical prevertebral collection and an epidural collection at C2 to C5 with spinal cord compression. This abscess was surgically managed. The patient had a prolonged hospital course, and after 72 days of hospitalization, he was discharged to a rehabilitation unit with improved muscle strength, autonomous standing, and feeding. The point of bringing up this case is merely hypothesis generating. It's easy when the patient has objective weakness, but it makes you wonder, were there any clues in the exam that may have popped up between that first visit and those intermediate assessments before the patient finally presented with objective weakness a month later. This patient had an abscess between C2 and C5, and maybe a more thorough exam could have decreased that diagnostic window. With this in mind, let's talk about spinal epidural abscess. What is a spinal epidural abscess? Well, it's an uncommon condition. It occurs about 2 times per 10,000 cases of back pain seen in the emergency department. It refers to a collection of pus, infectious material located in the epidural space, superficial to the dura mater, which surrounds the central nervous system. It typically occurs from hematogenous spread, extension of nearby infection, or iatrogenic inoculation. Staph aureus is responsible for the majority of infections. 20% of spinal epidural abscesses occur anterior to the spinal cord. These lesions are typically associated with osteomyelitis and are thought to cause more systemic features, which can make them more obvious. Unfortunately, 80% of these occur in the posterior region, and these patients are less likely to experience systemic symptoms, such as a fever. For an excellent overview of spinal epidural abscess, I encourage you to revisit this excellent blog post by Dr. Syed. It provides an excellent overview of why this entity can be so challenging to diagnose, and then highlights how to approach this entity. And having reviewed many of the review articles and case summaries in the literature, many of them do have a similar collection of take-home points. I think that can be summarized pretty quickly. It's hard to diagnose, it's vague, and it's non-specific. Think about in the individual with low back pain, maybe they're going to have a fever. The back pain is more commonly lumped under that category of low back pain because that's the pain we most commonly see. If you have suspicion, or if the patient's had recurrent ED visits, send off an ESR or CRP to better risk stratify. If your suspicion is high enough and inflammatory markers are elevated, the patient needs an MRI of the spine. Skip lesions are common, so make sure you image the entire spine. And then it's kind of like good luck, this remains a challenging diagnosis, consider this approach, and that's kind of where it's left. With that in mind, I want to highlight a review article on spinal epidural abscess published in 2000. And this is an area without a ton of new literature, but diving deeper into this, one thing that I think is often very underemphasized is the epidemiology, and specifically on location of abscess. Localizing 738 cases in this article from cranial to caudal, we note that 19% are cervical, 7% cervico-thoracic, 35% are thoracic, and 7% thoracolumbar. 30% were localized to the lumbosacral region. Why is this important? Well, it means that over 50% of these occur outside the lumbar spine. And from what we have previously emphasized, this is a very different clinical examination. Working our way caudally to cranial, abscesses at different levels will present with very different findings. Below L2, we anticipate our classic features of cauda equina that we all know well: urinary symptoms, stool incontinence, saddle anesthesia, decreased rectal tone, lower extremity weakness, and decreased reflexes. Above L2 and in the thoracic spine, you need to specifically look for somatary sensory symptoms and upper motor neuron lesions. These upper neuron findings will be confined to the lower extremities. Moving higher into the C-spine, we anticipate similar findings in the lower extremities, but now you also need to consider upper motor neuron findings in the upper extremities. Do you want to check those upper extremities for hyperreflexia, weakness, spasticity, and Hoffman sign? So the big take-home point, spinal epidural abscess is going to continue to remain a challenging diagnosis, but I think highlighting the localization gives a better chance of shortening that diagnostic window. 50% of spinal epidural abscesses present outside the lumbar spine, so make sure to tailor your physical exam to give you a better chance at lesion localization. And because many of these lesions present with the lumbar spine, this is why we advocate for imaging the whole spine when suspicion is high due to skip lesions. All right, metastatic disease. So this is a case I saw on the second visit. A 75-year-old male, previously healthy with a couple-week history of worsening back pain. Exam, labs, and x-rays are performed, and they are all noted to be unremarkable. After a pretty thorough workup, the patient was sent home with suspected MSK back pain. 1 month after the patient presented with continued back pain since discharge, he had progressed to the point where he was spending his entire day in bed, and if he was standing, he needed to lean forward to alleviate the pain. On exam, tenderness was noted in the thoracic spine, and the lower extremities. The right leg was normal, but the left was more rigid. He was hyperreflexic in the left leg at the knee, so he was spastic in the left leg with hyperreflexia. So we note 2 features of upper motor neuron findings in the left lower leg with accompanied thoracic pain. Additionally, the patient had significant tenderness in the lower portion of his abdomen. So I was debating on imaging, and then I decided on a CT abdo-pelvis because it may answer both questions. So the donut of truth gives all the answers. First, the back pain is explained by a T9 compressive fracture with an underlying lytic lesion with retropulsion into the spinal cord with additional lytic lesions at T12 and L2 and L3. Interestingly, the inpatient progress notes on this patient on many occasions comment on the absence of features of cauda equina, which I hope from today's commentary will make you realize that that doesn't make much sense. The abdominal pain was explained by a left iliacus hypodense lesion that was well circumfrised. This was felt to be from an underlying metastatic lesion of unknown primary. Further workup revealed a primary lung adenocarcinoma. The patient received palliative radiotherapy to his spine and eventually underwent MAID not long after. So why do I highlight this case? Well, in 2020, Wool published a review article examining the epidemiology of spinal cord and column tumors. The spine is a frequent location for metastatic disease. Breast, lung, and prostate cancer are the leading contributors to spinal mets. These mets can manifest as bone pain, pathologic fractures, spinal instability, nerve root compression, or in its most severe form, spinal cord compression. Efficient identification and workup can help expedite treatment and improve quality of life. The most common location for spinal mets is in the thoracic spine, followed by the lumbar spine, and lastly, the cervical spine. So 70% of these will be in the thoracic spine. Putting this together, we know from previous, compression of the thoracic spine can have autonomic symptoms, somatosensory symptoms, and upper motor neuron findings. It's important to make a diagnosis when possible, as malignant spinal cord compression can be treated with dexamethasone therapy and possible emergent radiotherapy. So my big take home, primary cancers that metastasize to the spine more predominantly affect the thoracic spine. And so make sure you're tailoring that exam again to give your chance itself a better lesion localization. All right, the last thing we're going to talk about is transverse myelitis. So for this, I'll briefly highlight what transverse myelitis is, because it's a rare diagnosis and one that's talked about but not commonly seen. So what is it? Transverse myelitis, it's a rare disorder. It occurs in about 5 people annually per million. If we break it down, it essentially indicates transverse inflammation of the spinal cord. It can occur at any level, but it most commonly affects the thoracic region of the spine. The differential is broad, but can result from viral, systematic disease such as lupus, cancer, or MS. Symptoms typically progress over the course of days and months. Common clinical features may include neck or back pain in association with neurologic complaints and findings on its physical examination depending on spinal cord level involved. If a patient is experiencing inflammation of the spinal cord, again, we could possibly expect autonomic symptoms, somatosensory symptoms with a clearly defined spinal level, as well as upper motor neuron findings. MRI may demonstrate lesions of the spinal cord, but MRI findings may lag the clinical presentation, especially early in the disease process. In these situations where the patient has definite neurologic findings that are consistent with compression but has a normal MRI, transverse myelitis is one of the primary working diagnoses. In such cases, neurology needs to be involved and consideration for a lumbar puncture needs to be done. The spinal cord commonly demonstrates the spinal fluid commonly demonstrates signs of inflammation, such as lymphocytosis and elevated protein. Treatment may include corticosteroids, plasma exchange, and disability is common despite treatment. So again, I want to highlight a case. This is one I pulled from the literature. I pulled this one because it's a rural farmer from Ontario, and it highlights how challenging this diagnosis can be. But again, I think lack of inadequate assessment plays a really important factor in delays in care. So a 61-year-old farmer presented to a chiropractor's office for back pain. A full assessment neurologic testing was performed, and it was reportedly normal. A couple weeks later, the patient began to experience a number of troubling symptoms. He was having trouble walking properly, coordinating his feet. He had interscapular pain and numbness in his fingers bilaterally. If he got onto the ground to do some work, he couldn't get up by himself. He followed up with his family physician, and he was diagnosed with a viral illness, and no neurologic assessment was performed. Over the course of the next couple of weeks, the patient followed up with a new chiropractor several times. He had multiple adjustments done, but he didn't have a neuro exam performed, and there were kind of some weird diagnoses of back pain, maybe a lock tip. And finally, the patient followed up with their family doctor again. Notes of the exam are not available, but an urgent neurology referral was sent. And shortly thereafter, the patient was seen by neurology, where he was given a diagnosis of transverse myelitis. MRI of the spine revealed high T2 signal in the thoracic spine at T5 and T6, suggestive of edema. The neurology assessment at the time revealed the upper extremities were normal. Again, lower extremities, bilateral spasticity, no clonus, 3+ reflexes, 2 to 3 out of 5 strength, bilateral upgoing plantar responses, good rectal tone. These are all findings that might be expected based on what we've covered. The patient was admitted for IV steroids and additional workup. So coming back to this patient took about 5 weeks from onset of symptoms before he was seen by a neurologist. I think it's worth wondering if a more tailored exam may have helped shorten that diagnostic time frame. In this case, the patient had a terrible outcome. They were wheelchair bound, catheter dependent, and suffered a number of other related complications. So having covered a number of different disease entities, I think it's important to try and put everything together into an approach that you can use on shift. The reason I've harped on the physical exam so much is because it's probably the most important part of the approach, and it's really nothing fancy at all. The most important step in the approach is clinical suspicion. Focus history and physical exam that makes you think the patient has an acute myelopathy. In the elderly, prolonged progressive symptoms may lead you down the road of degenerative cervical myelopathy. Fever and low back pain may lead you to think about spinal epidural abscess. It's going to vary from patient to patient. When the patient reaches that threshold, they need imaging of their spine. They need an MRI of the spinal cord. Location and timing of imaging locally will be decided in consultation with radiology. The purpose of the MRI is to rule out a compressive lesion, as based on exam alone, this can't be distinguished from other inflammatory pathologies. In discussion with Dr. Kontolamos from neuroradiology, it is generally accepted that they would image the whole spine for cases of things like suspected spine infection with epidural abscess, suspected epidural hematoma, or new Mets, as the extent in these entities may be or is often multifocal, or in the case of hematoma, can be long and extensive. Generally, spine MRIs performed at TOH for suspected infection are done with contrast. Cases of suspected hematoma or malignant metastatic cord compression are usually done without contrast, as it doesn't add much diagnostic benefit. So if a patient with an acute myelopathy has an MRI of spine requested, if there's no specific concern for infection, they'll usually start without contrast and bring back the patient later for contrast if needed. So the MRI, if you do see signs of compression, you go down your compressive differential, which can include trauma, degenerative cervical myelopathy, tumors, or epidural collections. If there are no findings of compression on an MRI and the patient has significant symptoms, the patient likely warrants consideration for a neurology consult and an LP for diagnostic therapy. The purpose of the LP is to look for inflammatory changes. If the LP is not suggestive of inflammation, your differentials include metabolic or toxic changes, radiation changes, paraneoplastic, vascular etiologies like early ischemia or a spinal dural AV fistula, If the LP is suggestive of inflammation, there are multiple etiologies. We have viral, bacterial, multiple sclerosis, lupus, and sometimes idiopathic. So to wrap up, I'd like to go over some of the take-home points from earlier today. Think about your physical exam. Think about how you can incorporate searching for upper motor neuron findings into your exam. And if you don't, you're never going to find them. In terms of degenerative cervical myelopathy, the true incidence is likely higher than reported in the literature. Patients frequently experience delays in diagnosis, and in many cases take years to receive a diagnosis. Delays are multifactorial, but inadequate assessments by frontline providers are likely contributory. So remember this diagnosis and keep it as part of your differential for that elderly patient with progressive weakness, gait disturbance, and falls. So remember it and examine for it. Spinal epidural abscess is going to continue to remain a challenging diagnosis, but think 50% of spinal epidural abscess are going to present outside the lumbar spine. So make sure you tailor your exam to improve that diagnostic yield and give yourself a better chance at lesion localization. Primary cancers that metastasize to the spine most predominantly affect the thoracic spine. So again, it's important to tailor that physical exam. And lastly, in a patient with myelopathic features, consider using this framework to help guide workup and management. You know, prior to imaging, it's really hard to distinguish between compressive and non-compressive etiology. So that MRI is really to rule out compression. And then from there, neurology and an LP consult can help distinguish non-inflammatory versus inflammatory etiologies. So I'd like to thank my supervisor, Dr. Emma Ferguson, our local neurology expert, Dr. Stratton from spine surgery, who graciously answered some of my questions, as well as our neuroradiologist, Dr. Meru Contolomos, and Dr. Trevor McGrath. My daughter, Sophia, who was born last week, who kindly asked me to review this rounds at 3 a.m. last night. And that's all I have. Hashem.
Comes up a lot, but
whatever I've seen in the literature, it's always been 200. That seems to be like from all the sources that I've seen. Yeah. Max. It's easy when they have classic symptoms. So the most commonly is neck pain. So if someone comes in with like neck pain, it's going to be a bit easier. In the case that I saw, the guy didn't have neck pain, so it made it a bit harder. So then the symptoms are more non-specific. But generally the classic is neck pain with like bilateral hand numbness, loss of dexterity. Patients may say they had like trouble buttoning their shirt. Like that would be a common symptom. Yeah. Sean. Yeah.
So the first one for the PDR, I think it's an important reminder that, like, when you think about post-void residual, you tend to think of the elderly patient. So a person with BPH, post-void at 200 cc's is probably unreasonable. If you have like a 28-year-old, you really shouldn't have like BPH causing BPH. If you have a 200-year-old, that's action.
Yeah.
So it's just to kind of reflect on like where that patient should be on the spectrum. The other comment is, I think that you brought up a really important point that is important to reinforce, that when you think about chronic planning, because the report is active, you typically get lower motor neuron findings. So if you're getting somebody who has back pain, maybe low back pain, they have weakness, but then you get a flare that it could be more upper motor neuron findings, it just gives you strength to advocate that that should be a full spine rather than just a lumbar spine.
Yeah, I think there used to be the advocate with the CT myelogram, but in talking with neuroradiology, I think the standard is an MRI of the spine. So that really should be the best test. I think if you have I have had discussions with radiologists before where overnight, a CT can be a good quick test to start, but if you still have high concern, like the patient does need that MRI later. And I think you raised a good point, but I think your exam can help you be a better advocate, because I've been at M&M rounds throughout the course of my residency where there were missed thoracic lesions, and the take-home point was you should have just examined the whole spine. But I think you can be a better advocate for the patient. You say, I need the whole spine imaging because there's these findings on exam that localize, as opposed to just. Scott.
So that's just a question, but these people, like, if they have equivocal findings, like basically pain and maybe some sensory symptoms, but no motor weakness, and if we're needing an MRI to diagnose and rule out the degenerative and
Yeah.
morbid condition, the wait time for consultation for spine or neurology is well beyond when a patient can get away without symptoms. So we'd be ordering these through the emerge, I imagine, likely as an outpatient. So would you advocate for an outpatient like PT MRI?
So what I can say is I've been thinking about this kind of gradually over the course of months, and I've changed the way I examine patients. And this hasn't made me order any more MRIs than I did previously. And in this case of this patient that was doing poorly, this was like a really highly functional 80-year-old who worked full time. If you start examining patients from like long-term care and who don't have like high functional status, they may have these features, but you probably won't see with imaging. But I think if the patient needs the test, they need the test. So I think it's going to be staff dependent. So I guess I don't know how to appreciate the workflow for imaging. Like, I think if they have subtle features, it can be done through their family physician. But if your suspicion's high enough, I think an outpatient is reasonable. But I think that would need to be like a departmental policy on that.
I just bring it up because it's obviously sort of hesitation around ordering outpatient within the department is something we have to follow up on. But current follow-up with neurology and spine is not
Yeah.
for this.
Yeah. Sweet. I'm going to wrap it up.